Hello, everyone. Thank you for having me. I'm Jo Witchard. I'm the lead digital midwife at Gloucester and on the CNIO panel for digital health networks. There's a lot going on at Gloucester at the moment. We are becoming in the process of becoming a digital data bank with the Things Foundation. We're looking at procuring a neonatal EPR and digitizing our emergency checklist. There's lots going on. We're also looking at dashboards for audits and data quality with our BI team. So really, there's something to keep me very busy all of the time.
Jo, Karen, can I come to you next, please?
Hi folks, great to be here today. My name is Karen Bridgman, digital midwife at Morecambe Bay. I have a very special interest in AI and I'm doing a lot of work currently with various AI networks, and I have a newfound interest in research as well, so I'm getting quite interested in making sure that we've got plenty of research in the midwifery sphere, and looking forward to doing a bit more work on that aspect. Morecambe Bay currently we have just procured neonatal EPR, and we have gone live with Good Things Foundation and begun handing out our free SIM cards, which is great. Also on the CNIO panel with Jo.
Perfect, thank you, Karen. Dawn, if I can come to you next, please.
Yeah, thank you, Carl. Good morning, everybody. And thank you, Carl, for inviting me to come and speak today. And it really is great to be here. And I'm absolutely buzzing to see so many digital midwives on the call. It's just nice to have those friendly, familiar faces. So good morning, everybody. You know, it goes without saying, the digital midwives know who I am, but I'm Dawn. I'm the Deputy Chief Midwifery Information Officer at NHS England, and I sit in the Transformation Directorate. Predominantly, I am in Helen Bolsden's team, who is the Chief Nursing Information Officer for NHS England. My focus, it won't come as a surprise to the midwives on the call, is reducing digital inequalities. So I'm really a huge driving force behind our Fixing the Digital Divide project, and hopefully we'll probably touch on that during the call today. So thank you.
Dawn, Misbah?
Hi, good afternoon, everyone. It's lovely to be here. I'm Misbah Mahmood. I'm currently the CXIO and Clinical Safety Officer at Bradford District Care Trust, which is a community and mental health trust. And I'm a midwife by background. I'll always be a midwife, and done quite a lot of work with digital maternity. And I think stepping into the mental health space, I'm really interested in the interoperability side, and how we can really enhance our sharing of data as well across organisations, but also across specialities.
Misbah, and last but not least, Jackie.
Hello, I'm not a midwife, and I'm the first to say that I am a Chief Nurse and Information Officer, but my clinical background is neonates, and I have lived and breathed neonates all over Cheshire and Merseyside, and digitised the level 3 unit that I ran probably about 12 years ago, actually, one of the first of type neonatal units to digitise. So I've got lots of experience there. I'm always an advocate for my midwifery colleagues, as I've worked so closely with you along my clinical career. I'm the CNIO for Health Innovation Manchester and NHSGM, and I'm currently doing a huge amount of work for digital maternity across Greater Manchester.
Brilliant. Thank you, Jackie. Thank you, everyone, for joining us today. Really appreciate the time that everybody gives up for these, and hopefully our audience have really got some insight into various different aspects and fields as we've done these and continue to do them. I am going to pick a fairly big topic to begin with, and I'm going to come to you, Dawn, on inequalities. So let's start there, please, Dawn. Thank you.
Thanks, Carl. Oh, it's always great to be first. So can I talk about digital inequalities? Because I think since the 10-year plan was published and the ambition to move from analogue to digital, which is great, so it's absolutely fantastic, and that shift is going to be transformative for the whole of the NHS. But the thing that concerns me about that is the risk of increasing the already existing digital exclusion that we know exists out there. So there are 10 million adults in the UK that are already digitally excluded, and that's through lack of skills, lack of access to a device, and lack of connectivity. So we know that this is an impact on maternity services. We know that our vulnerable women are being further excluded through digitising our services, and that's why we are driving our Fixing the Digital Divide project. So for those of you that don't know, maternity services have been collaborating with the Good Things Foundation charity, and in that collaborative partnership, maternity services that have set up maternity digital hubs are gifting free data in the form of a SIM card to women that need it, and also, where possible, refurbished mobile devices. So to date, we have gifted over 230 SIM cards and over 90 devices, which, when you think about it, is remarkable. 230 families out there now have access to the internet. Women have access to their maternity records. So that to me is such an important aspect of the work that we do, because when you read reports that says hospitals have got to save money, they've got to cut staff, unfortunately it's digital that always seems to be the default setting to reduce the level of staffing, and actually we're so critical to the workforce as a whole that we really need to pursue this. And just as an added little addendum, and then I'll shut up, we are planning to extend our Fixing the Digital Divide service across to neonatal services. So watch this space.
Dawn, just continuing on the inequalities themes, because there's always some pockets of detail. I'd like to come to Misbah next.
Yeah, I think the work that's been going on with the Good Things Foundation is amazing, and we've definitely seen some improvements of that as well. But I think we need to really think. So we did a piece of work when I was working at Leeds Teaching Hospitals, and we looked at our health inequalities data. So we use the data that we collect showing the booking appointment, which is usually an hour and a half, and we really utilise that data to show us, we have all the national reporting, but it was kind of what is our local data showing us, and how can we help our local population? And actually from that what we found was that 50% of the women that were giving birth were from a deprivation index 1 to 4. So that's the lowest deprived. And the average reading age in England, I think, is like 9 to 10. So we really looked at kind of the information that we're sharing. Is that actually readable and understandable for our population? So are women making a truly informed choice? And also as well, and I think I always use this example, and my grandma would not be very happy, but I can speak Urdu and Punjabi, but I can't read or write it. So if someone gave me a leaflet, I wouldn't have a clue. But we developed something and introduced something called Reach Deck on our trust website, which means it would read out the page in whatever language you selected it to. So it would also translate it, but it would also read it out as well. And I think it's kind of looking at those different ways that we can use technology to enhance the care that we're providing as well.
It's super helpful. What was the translation that you used? Can you remember? The readout, sorry, rather than translation.
It was called Reach Deck.
Reach Deck, thank you.
Yeah.
Just want to log, thank you. So Karen, could I come to you next?
Absolutely, and probably just talking on the back of Misbah's conversation there, I think our priorities actually in the next couple of years need to be around the equality data. Absolutely, trusts need to be focusing on developing their local dashboards with inequality information within it. We've done similar to Misbah with a local dashboard for looking at various aspects of health in general for our maternity population, including deprivation and ethnicity as well. And some really obvious results coming out of it, and some quite unusual results coming out of it as well, which doesn't necessarily reflect some of the national reporting. So even though we have these amazing Embrace reports and we know the inequalities that are displayed in those, it is really key to be looking at your local demographic and making sure that you're covering your local region and services. So I think that's a real priority for maternity services at the moment in developing what they can see, and on the back of that, like when we develop anything data wise, making sure that the data behind it is actually good quality. So your first steps is to make sure that your ethnicity data is good and that you've got some good BI support behind you, like I have. And I've got to say that because they're on the call. And and making sure that you've got some really good BI teams to be able to pull that data out for you and display it in a really good fashion. And lastly, making sure that you've got the narrative around it to present that to your senior teams, so they can really understand what the picture is being shown on those dashboards. So it's really key to get that narrative across as well.
Karen, is that part of a wider organisation, population health management lookup for data, or is it specific within maternity services?
So we tend to focus on quite different information for population health. So we're much more granular in looking at what's happening within the pregnancy period. So we do tend to step away slightly from the general public health pieces of work, but I definitely have looped in with them locally so that we can understand what they're looking at and how they're looking at it to get us started really on that journey. So really valuable colleagues to be getting in touch with to support that as well.
Thank you. Jackie, could I come to you with on the angle of neonatal, please?
So I think just a couple of important points to make. So the data that we get out the back end of the system is only as good as the data that we put in the front end of the system. And what I would say in my experience is we have a plethora of systems. We know at GM, because we've done a huge piece of work with McKinsey around how many systems we expect midwives, neonatal nurses, etc. to use in one episode of care for a woman, and that can be 4 to 5 different systems and paper thrown into that as well. So when we talk about data and the importance of data, we must work harder for our midwifery colleagues and our neonatal colleagues to make sure that they have a single source of truth. They have the mantra of document once, populate many. So they're only putting the information in once, because the minute we start asking them to put it into 4 or 5 different places, we know we've got high risk there, and we know we've got bad data out the back end. And I think it's acknowledged at national level that that's certainly the position that we're in. So we need to push our suppliers harder, much harder actually, for the systems that we are asking our end users to use. And I think the other point is, well, I always talk about it, infrastructure. So is the kit that they've got the right kit, and can they connect? Training. So do they really understand the importance of logging and putting in ethnicity? Because what we know is nationally our ethnicity data is really poor actually, and I think some of that for midwifery is because of the multitude of systems that they've got, the time limit they're at with the woman, and how many times they have to document. So I always say, as a midwife, I think they've got the poorest experience actually of digital technology, and that's because they've got this multitude of systems, none of which are interoperable, and the enterprise architecture just isn't there for them. We must work harder for them, so they're putting it at once, and it's documented many, and then we've got great data at the back end that we can use.
I'm just going to come straight back on that, Jackie. I'll come back to you in a moment, Misbah. I just wanted the question around mandatory fields. So you've mentioned there about ethnicity, and I imagine with some of those are options on the R&D designed to make those you must enter this. I just wondered where the frequency was with that, people.
So I'm not a huge fan of mandatory fields in the many go lives I've done and the optimization I've done for years. What you end up is, certainly for me, colleagues asking, make that a mandatory field, make that a mandatory field, and actually it becomes a really, really poor end user experience. And the Class Arch Collaborative tells us that clinicians don't like masses and masses of mandatory fields. It's education. So it's making sure that they connect, the system works for them, they put the data in once, they understand the importance of the data, so we're getting it in. We can't make everything a mandatory field. We're professionals with professional judgment. So back in the day on paper, nobody tapped us on the shoulder and said, you must complete this. Did you write that on that piece of paper? It's just the job that we do. But what we're not doing is making it easy for them. We're not giving them structured data. We're not giving them dynamic documentation, and we're failing the end users in the documentation that they put in.
Misbah.
Yeah, just completely echoing what Jackie said, and I think that's what we found as well when we were implementing maternity EPR. And I think as well, so what we found is that structured data is good and yes, no fields are good, but actually what we were finding is that we were looking at our data and we were having loads of cord prolapses recorded, but that wasn't matching our data reporting, and that was when we looked into it. It was because it was in a set of questions, and there was 4 questions, and the answer to every other question was yes, and it's hopefully should have been no, but at 4 o'clock in the morning when you just like tick 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 tick, it was just being ticked. So we then added in prompts to say, are you sure you wanted to enter this data? And then as part of the maternity services data set submission, we get marched down if a sequencing isn't correct as well. So for example, if the baby fed before it was born, so we'd add things like that and like prompts into the system as well, because at the end of the day we are all human, and at 4 o'clock in the morning everything looks the same. So we really looked at what our UI is, and we worked really closely with the supplier to make sure that we were not tripping people up, but we was helping and supporting them to ensuring that we do get that accurate documentation.
Ms. Joe, I'm going to come to you, and you've also got you're going through the process of implementing a new EPR system, and I just wondered where that's in your kind of program in terms of what you're looking at for kind of data fields and data quality.
Yeah, sure. So one of the things that what Jackie was just saying about the different systems and putting in something many times in different systems, etc. At the moment, the example of that we've got at the moment is that a birth occurs. So the midwife will put that on our maternity EPR. I wonder if you can guess what that one is. And then she then has to go onto the PAS system and put that in so that you can admit the baby. And then what they are also asking for us to do is then go onto the trust-wide EPR, and that's where we would then print off the baby labels. And I'm just like, this is insane, because this is birth. This is when you're most busy. Also, delaying getting those babies' wristbands means that if that baby's sick and needs to go around special care, you're delaying that baby's care as well, potentially. So let's be a bit more logical about this. And so I'm pushing back on how can we make this a bit better? And I've asked, can we get some sort of automatic bot to do this for us? You put in the date and time of birth on the maternity EPR, and it's also got the place of birth and other details, and then it can use that information to admit, and then it uses that information to print, and you only have to do it once, and once you put it on, a couple of moments later there's your wristband, and you don't have to go in out, and with all the password resets and all the problems that comes with. And then about the specific question about the maternity, the neonatal EPR, we're still very much in the early stages of procurement. I would love, just because I know that the conversation between our maternity EPR being Badger would make much more sense to have our neonatal system as also Badger, and the conversation would be much better. But we are having to go through the due diligence of looking at other neonatal systems. And I've got real concerns that if we implement an additional system that's just for neonates, that's got nothing to do with what we have elsewhere in the trust, then we just added another system into the mix that has to somehow integrate and interface with the current systems and with all the areas that's going to come up with. So I hope that the guys that are working on that project will do a full circle and come back and go, maybe we should just do what I feel is most sensible, and to stick with the same system so that the conversation between neonates and maternity can be a little bit better. But I'll just have to wait to see if that is the conclusion in the end.
Hey, Joe, I think one of the things you started to touch on there with the disparate systems, and people have had this in a lot of places where they might have a single EPR, but they've still got 1,000 applications, and applications just old person's words for different software systems, and trying to get them all to be used. And for me, this talks about productivity. And I think some people get a bit spiky when you mention the words productivity, because they think it means you've got to work harder. Actually, you're misworking here, aren't you? Because you're rekeying, re-entering, waiting for systems, and that isn't productive. So it's that workflow of digital productivity, which we're talking about here. Karen, I'll come to you then, Jackie.
You've fairly much taken the words out of my mouth, Carl. So what I was going to talk to as well is that this, and I very much feel like it's a role of a digital midwife as well in really getting those processes nailed down. So really going through that workflow in detail, and then you've got that potential as well, as Joe said, where you can automate certain aspects of those processes potentially, but getting those processes really down on paper, clearly defined, is the key, probably, challenge in some cases.
Karen, Jackie?
Yeah, I think less about productivity and more about efficiency, and I think that that's not an unrealistic ask. We need to be efficient in the job that we do, and we're completely inefficient if we're using a multitude of systems and logging in and documenting multiple times, because the risk is very high there, and we know that. So if you talk about efficiency and safety, that's where we should be at. I think, and I will say it's controversial, but I feel I can say it because I've done neonates for years. We as neonatal nurses, midwives, are a victim of our own circumstance, because I would say for the last 15 years we've been talking about how special we are and how we need special systems to document about our women and our babies, and actually what we've ended up with is no link to the wider organisation's EPR, and we need to talk much more about a holistic view of a woman and a baby that grows into a child and an adult, where all those records are linked. And actually, because of our shouting from the rooftops that we're different, we've ended up with completely different systems that don't talk to each other. The fact that a baby can be born in the next unit, the next ward to where I worked in neonates, and there be no link at all to that baby that I admitted onto my unit in NICU to the woman's record who was next door. So I think we need to review where we are with women, babies, children, health and big EPRs, and get the whole lot linked, because actually pregnant women get sick and pregnant women get admitted to general wards whilst pregnant, and there is no link to any records. So we need to make sure we're looking at enterprise architecture, helicopter view of the woman's and baby's journey throughout the whole, from start to finish and beyond, birth to grave, and that's what we were all about, birth to grave. So we need to make sure digitally we're enabling that, and currently we're not.
Sticky, I know that NHS England are looking at that wider kind of helicopter view of architecture, which is going to filter down on quite a few areas, but it's not there at the moment. And I think Alec and Ming will be the first to tell you it's not quite there, but it's a work in progress. I'm going to come to you, Joe, and then over to Dawn.
Yeah, thank you. The automation would make a huge amount of difference, and when you talk about productivity, and I think that's what they are looking at when they are trying to when our teams who can do the automation are prioritizing. But for me, it's not really it is about productivity, and it's about time saving, and that's the question they keep coming back to me is, okay, well, which one of your 5 or 6 use case for automation is going to reduce the whole time equivalent workload of any group of staff? That's what they keep asking me. But actually, my comeback would actually be, it's more about clinical safety, and you've got to remember about clinical safety, and there are lots of use cases where automation would improve that clinical safety, and that situation at birth when you're having to go in out to get the right thing, it impacts on clinical safety in a separate but more important way, because as I said, with that sick baby going to special care, you need to be able to give that care quickly, and there are lots of other examples as well. But and actually, just Jackie, listening to you talking about how we've said for such a long time as midwives that we're special. Actually, I've never thought of it like that. That's really interesting. That I've heard it said, and I'm guilty of saying it myself, that in what other situation in the hospital do you go in as one patient and you leave as 2 or 3, and therefore we're special? That's a really good point. And how are we actually victims of our own self-induced specialness? But I think some of this really has to, the responsibility of this has to be pushed back on the supplier, because we are only as good as the product that we've got at our fingertips. We can design the processes around the product, but actually the product needs to be designed around the clinical effectiveness and quality of what we're trying to achieve.
No, you're right. And I think in the past, some software has been specialized around reporting and what information you need to put in and what information you need to get out, rather than actual the workflow itself. User-centered design is often thrown out there as a as a kind of nebulous answer, but actually that's what it means. It's, you know, it's actually you designing it for it to work for you rather than the accountants making things work for them, because it makes their life easier to manage the data. Dawn, I'm delaying you. Please come in, Dawn.
It's okay. I've got 2 points to make. I'm sorry, Carl. I'm that one. So
All
my
right.
my first point is around the intelligent automation, and I know a lot of you will know, but there might be some on the call that don't. That Portsmouth actually did set up intelligent automation, and they use it for various reasons. And one of them was they had a huge backlog of referrals into maternity services that the admin team were dealing with manually. That was taking a long time. The backlog was getting bigger. It was like a bottleneck, and people were missing time critical scans and screening tests, etc., etc. So they introduced intelligent automation, and when women self-refer, the system reads the referral, it updates their PAS system, it creates a record in the EPR, it allocates a community midwife, creates the initial appointment and informs the patient, and books their first scan. So that's all done. And through doing that, they saved 17,000 hours of admin, and their backlog reduced from 2,200 to 400 records. And obviously staff morale was improved within the admin department. So, you know, it's not just about those numbers, it's about the people that are involved. And the other thing that when they did the automation, what they discovered was, hang on, because I've made a note of this because it was so good. The time to book a nuchal fold scan after a referral reduced from 4 weeks to 24 hours. So that's massive. That's absolutely huge. And then I wanted to pick up on a couple of things Jackie said about the lack of interoperability and the nightmare that causes for all of us. You're absolutely right. We are special, full stop. And I think the NHS England know this is a problem. The government know this is a problem. Hence, in the 10-year plan, it states quite clearly that we're working on a single patient record. Now, I've got a definition of a single patient record, because it's a bit lengthy. So the aim of the single patient record is to provide a single comprehensive view of a person's health information across all services, regardless of that person's location in the country. And it's really important for me to stress that the single patient record will not replace existing systems. So it will connect to EPRs, to federated data platforms, to shared care records. So there is a plan in place, but unfortunately it is the 10-year plan. So that is my only concern about that.
Dawn, Jackie?
I mean, completely agree, Donna. And so I suppose we need to work at a pace, don't we, to rectify some of the issues and the risks that we've got. Maternity is in the spotlight, as it absolutely should be, and we're looking for solutions to make us in a better, safer place for women. One of the solutions we're looking at in GM as a trailblazer, whilst we wait for decisions and plans and processes around the SPR, is to put a minimum maternity data set into the shared care record, and I think that's kind of a sticking plaster for the SPR. But actually what we know is for GM, a lot of our women, and I know this is nationally because I've worked in other regions, a lot of women shift around the region to different providers, many because of high risk clinical issues, but actually some for safeguarding issues. So before you've got the information about the woman that you've delivered, the woman has delivered and gone, and that's high risk for us in clinical areas. So what we're doing at GM is we're looking to utilise the shared care record to put a minimum maternity data set in. So wherever that woman lands within GM, and we have a high proportion who move around, the clinician, obstetrician, midwife, whoever, will be able to look into the shared care record and see a minimum set of data to enable them to act on high quality care delivery. It's very difficult for our public to understand that we treat people with very little information. They presume that we can see everything about them, and because midwifery for pregnant women is a hybrid, some paper, a bit of digital, very often they don't bring the paper with them if they go into labour early and they're somewhere else. Trying to make good, safe decisions on the woman in front of you is a really hard thing to do. Midwifery is the highest clinical setting for litigation. So we've got to enable clinicians to see something, a minimum data set of the most important information in front of them in order for them to make safe decisions. So at GM, once we've done that, the plan is, and certainly, for the CONCA call, which is the National Group for Shared Care Records, we're looking and seeing if we can lift and shift that to other regions until we get to the point where we know where we're going with the SPR.
Good point, Jackie. I think there's quite a few people who've done some good work with shared care records, and let's not throw the water out with the proverbial just because we've got some new shiny things coming as well. So no, very good point. As you have mentioned, the single patient record, and it has been mentioned at our summer schools by people like Ming saying this is going to be the first thing that we're going to do, maternity. I've currently got a big old fat red book for my children, which when they were little, in the other room with silly charts on, which occasionally you forget it and someone hasn't got it, and there's a different appointment in a different vicinity in a different organisation who doesn't have your details. So how are we going to fix it, Dawn? What's the single patient record going to change, and how are you going to get it to a point where you've got that kind of national data set from everybody with all their disparate services, disparate systems, working on a new single platform? It's a big question, I know. Thank you, Dawn.
It is a big question. I wish I had the answer. But what I can tell you is that the single patient record is currently in a test and learn phase. So even the single patient record team don't know yet what it's going to look like. So we're working at establishing that. And obviously midwifery is the first to be put through this process. So it's really important that we get this right. I think it's also important for people to know that clinicians are involved. So we've held a workshop already. Digital midwives and obstetricians were invited along. If anybody on the call would like to get involved in any more workshops that are held, please do let me know. It's really important that you all know you have a voice. The single patient record survey went out asking for clinicians' opinions. It's really crucial that you complete that. Again, I can share the link if people would find that valuable. But what is important is we've got to learn from past mistakes when they've tried to develop and implement large tech in the past without having any clinical input. It failed, it costs a lot of money. So this time we are involved, and I think that to me is the most crucial point around the single patient record. I will get that link and then I'll show it.
Karen, can I just come to you on your view of the single patient record and how you think this is going to work? Because there's going to be work that's going to be needed from you guys locally.
Absolutely, and I think what we've got to acknowledge is this is going to be not necessarily just a staff-facing record. This is a patient-facing record as well. So it's going to be a very interactive looking record, hopefully. I think the work that Jackie and some of the other trusts have done with their shared care record is the foundation. I don't think we can walk away from that. I think we just need to utilise what's been done, make sure we've got a really, really clear data set for maternity services, and on the back of that, Jackie, neonatal information, and making sure that's really robustly developed before we go forwards with it. Hopefully the survey will bring out some findings from that, Dawn, and I think it was a really good touch base to get a feel for where we're all at currently, and I think there's still a lot of space for a lot of work to be done here, because some areas haven't been as embedded in their shared care work as others. So you can see where it's already making benefits in areas where it's already been implemented. And I think it's really key to move that forwards quite urgently in the next year or so.
Karen, Misbah?
Just picking up on what Dawn says, so obviously the 10-year plan is 10 years. and it'll be here before we know it. But also I think there's a lot of foundations work that we need to do to get everybody up to a level playing field, because even within every organisation, their usage of their EPRs, what EPR they are using, how they're interacting with it, what functionality they're using, it's so varied, and we want to make sure that everyone is on the same level, so that then when we are feeding that data into the shared care record, it's of the same level, as well. And I know that we've done like digital maturity assessments and things like that in the past, but we need to really utilise that data and strengthen the foundation so that when we move to the shared care record, it will be a smoother transition.
Elizabeth, Jackie?
Yeah, I mean, I think the DMA for large trusts, certainly for me in GM, we've got that data and we've got several years of that data. Dawn led with Jules, digital maternity maturity assessment, and the wealth of information that we've got from that now, certainly for me in GM, has enabled me to look at the landscape, look at the patch. I knew it in my head anyway, but actually there's much more detail from maternity and neonatal services. So that gives me the evidence from the providers at ICB level to then look at the plan and see what we're going to do with the plan. I think, you know, there's lots of talk of convergence, and we certainly looked at that across GM, you know, in terms of convergence, and that was something we considered, but we knew from a provider perspective we couldn't get. I think neonates have got convergence with Badgernet because there's all neonatal units are on Badgernet, so we can see that information. Maternity is different, and that's where the shared care record comes in as that data repository to dump the data in to make safer decisions. So I think you all need to look within your own regions, utilise your DMAs at provider level and the maternity one, and you'll look and see, I mean, at GM we've got vast differences, some really levelling up and some top of the shop. So trying to get equilibrium and equality of patient care for our population is a really difficult thing to do. So I think use that information, it's really valuable information, and I always say for digital midwives and CNIOs, use that data at board level. That's your data to utilise at board level, to get on those board meetings and say, this is where we're at, this is where we sit nationally, this is where we sit regionally, what is our plan to upskill, what is our plan to level up? And that, I think you should use that data. It's very, very valuable.
Thank you, Jackie. Dawn, would you like to come in?
Yeah, thank you. I just wanted to pick up on the DMA just to say there are 119 trusts in England that provide maternity services, and out of those there are 11 that still use paper for either antenatal, intrapartum or postnatal, and there are 2 trusts that are on paper end to end. So, you know, this is ongoing work. And then the other thing I wanted to pick up on was something that you said, Misbah, about using your EPR fully. And, you know, Jules and I talk about this all the time about how we don't use the tech in general that organisations have procured, so EPRs aren't being used fully. And, you know, how many of us on this call will use Copilot to then generate your meetings actions to go away with? You know, all this amazing tech and AI that we're not using. So I think my point being is optimization is just as crucial as implementing.
You're absolutely right. I'm trying to resist bragging about the fact that we've got a stage called optimization and implementation of Rewired, but I did it anyway. Misbah, to you, please.
Thanks for that plug, Kyle. But yeah, just picking up on that, Don. I think we've started doing this at Bradford, and we've just literally done a digital confidence review. So looking at our digital skills of our workforce. So if you all remember back when Teams was introduced and everyone suddenly just went online straight away, there wasn't that training and everyone just adapted to it. But well, we've kind of taken it back and looked at what is the skills of our workforce and how are they using our EPRs, what can we put in, what support can we put in, what training can we put in, as well, and people really taking ownership of that, because as we know, digital is not going anywhere and we keep introducing more, and obviously we've got AI and everything coming as well, but it's good to understand what skills our workforce currently have.
Absolutely right. And it's one of the topics that we've got down to talk about further today around kind of skills, digital workforce, what do people need? And also obviously for the patient as well, because we can't just put services out there and expect them to be able to interact and use it, which comes back to inequalities and exclusion. So Dawn, can I just come to you on that point, and then Karen, I'll come to you next.
I'm really sorry I missed your point because I was planning my own next point. So tell me what your point was, Carl.
So I'm talking about digital skills as part of the digital workforce.
Yeah, perfect.
So
it works.
That's
it works.
the generic point.
Yeah, right. So I'm sure many of you will know that we were expecting the digital workforce plan to be published. Well, that is not going to happen now. So it was announced earlier in the year that the plan was to incorporate that into the 10-year workforce plan, which is currently being consulted on. So the 10-year workforce plan refresh, there is another live survey asking for your views. So I'm going to share that link with you. But the emphasis will be on skill mix and training on using tech to increase efficiency. So I think it's really crucial that we get as many voices from clinicians that are using the digital tech into this survey. So can I share that as well, Carl?
Dawn, I know you've got a hand up, Joe, but Karen, I'm going to come to you first on what digital skills you think are missing and what is required.
So I'm really looking forward to Jo speak, actually, because I know she's got a really good analogy to share after. But one of the things that I did want to discuss today or mention today is around clinical safety officer training. It has been really, really limited in the past to very much an IT role and very much a focus on systems. And I think that's expanding massively. And I know there's a lot of talk with Helen Bolton's team around what the CSO looks like now, and is it actually a CSO? Is it should be more integrated into patient safety now? And I think it's really, really key for digital midwives and CNAOs to make sure that they are doing this education and training and seeking for the funding for it currently. I know there's been conversations that have been had previously around the costings, but it's really key and really important that we get more clinicians, digital clinicians, to be trained in this to support those aspects.
You can, Jo?
Yeah, I think that when the workforce are fully bought into the implementation, the change, and the digitalization, then it's much easier. But the problem is we've got a real mix, haven't we, in abilities, and there are definitely, I wonder, as we kind of go through time, and the younger workforce who have grown up with touchscreens, and they are much easier, they're just much more digitally adept, aren't they? As they come into the workforce and they start building and they start becoming part of the leadership, that will be a lot easier. But I've worked with specialist groups within maternity that have been incredibly digitally unconfident. I don't know, that's not the right word, but they are. And when I've gone to them and said, well, how about we change this process? How about we move this from a paper process to something else? And I've addressed it several times, and it just doesn't happen. Because they just don't have the confidence. And I with a very limited digital midwife workforce, I don't know how I'm meant to make that better. I don't know how, without badgering them really and saying, well, how about we do this? Because by remaining with this process on paper, it's adding clinical hours where, you know, a midwife, we are with women, aren't we? And I hear this phrase all the time that we're no longer with women, we're with iPad. And we can spend more times looking at our iPad or our desktop rather than looking at our woman. And is that to do with confidence? Is it to do with experience? And certainly as we go through and we get as we get our younger generation through, maybe that will improve. But yeah, I would like to know how we can help that. But Karen mentioned about my little analogy, as an illustration that I think kind of helps with, that I thought of the other day, that I think helps illustrate our responsibilities when it comes to digital exclusion, but actually it does work with our digital literacy in our workforce as well. So bear with me, I'm going to tell you a little story. So I cycle to work. I'm only 4 miles from work, so it's not a big deal. And for years, I was cycling on the road along with the cars, and I was almost on a daily basis, almost being run over. In the last couple of years, they've built a cycle path when it's on exactly the same route. I haven't had to change my path, and it's off the road, and it's a nice big green strip with a big picture of a bike on it. And crucially, my cycle to work now is much safer and it's quicker. In this illustration, if you picture that the cyclist is your patient, the road is the old analog way of doing things, and the cycle path is now the new digital way of doing things, and specifically like the digital front door. So the NHS app, or in maternity units, most of us are on Badgernet, so it would be the Badger Notes handheld device on your phone, app on your phone. And for me, it's my commute is quicker and safer, and for our patients, they are able to get their results quicker. They're able to get information leaflets quicker and translatable on their phones, and they're able to get their appointment reminders, which will increase safety, because that might be the appointment that we diagnose preeclampsia or IUGR, and we're able to optimize that pregnancy. But the other day when I was cycling home, there was someone cycling on the road parallel to me, and I just thought, it just got me thinking about digital exclusion. Why was he on the road when there's something safer and quicker that I'm demonstrating? And for most people, you see the cycle path and you go, I'll use the cycle path. Most people will be, there's the NHS app, I'll use the NHS app. But there will always be people on the road. And for the people that are left on the road, it's actually become more unsafe, because the car drivers are not used to seeing bikes on the road still, and we are less used to seeing people not using our digital solutions. So for example, we would just assume potentially that if we book an appointment for 3 days' time, they're going to get that alert on their phone. But what if they're not using that app? So what we can't expect them to do that. So we do need to make that phone call to say, by the way, I've made your appointment, or send a letter, and fingers crossed the Royal Mail will post it in time. So what do we do about those people on the road? So some of it is just they didn't realise that the cycle path was there. Let's get them moved on it. Let's signpost them. Let's educate. Let's get our digital inclusion officers. Let's upskill our workforce to help signpost people to the cycle path where it's safer. Some people might not have a bike. Let's give them a device. Let's give them a bike. Let's get them out of that digital poverty so that they can get themselves on the bike and somewhere safer. But there will always be people who want to stay on the road. And I think this guy that I saw the other day, he was full head to toe lycra. He was making a point that his road bike was for the road. He wanted to stay on that road. And there will always be people that they're capable and they're able, but they don't want to use the digital solutions. And that's fine. And I think that makes up less than 0.5% of our patients who decline use of the Badger Notes app. But we still need to therefore have things in place so that they can still get the information that they need. But an example of backwards signposting, in our postnatal ward, we have just developed a new paper leaflet, even after saying this, where we have put QR codes on it to and key information and bits and pieces, because we were realizing that women were not accessing the leaflets on the Badger Notes, which is a real shame, because what we've fundamentally done there is put people back on the road rather than putting them, we should have done a better job at moving them from the road onto the pavement, onto the cycle path. But what we've done is said, well, never mind, get back on the road, which is it's really frustrating as a digital midwife. Yeah, and I think that kind of speaks to a bit of the digital competence and literacy of the workforce at the moment, that their safe place is paper.
Absolutely, thank you, Joan. I'm conscious that we are whistling towards the end of our time, and we've only covered half of the things that we probably could do, but I just want to move on to the big capital letters of AI, which are throughout the 10-year plan, if you've read your 167 pages plus addendums. Now, obviously, AI is a broad term. It means different things to different peoples. There is ambient voice, there's ambient listening, there's bots, admin support, Copilot, Gemini. What do you think is going to make a difference both now, medium term and long term? Jackie, I'm going to start with you.
So it's the buzzword, isn't it? I mean, for me, that there's an absolute place for it. Safe AI implementation when we talk about digital clinical safety. And I think it's fair to say that the horse is bolted for a lot of the solutions that are out there. But I'm really pleased to hear that at the centre, we are trying to rein that in and ensure that we are putting safety first. I think there's several cases for it. The AVT, ambient voice technology, has been rolled out predominantly for medics, which is really disappointing actually, because nurses, midwives, AHPs are the biggest workforce and the biggest documenters in systems. And I will always say that, no matter how unpopular it is in certain forums, we are the biggest people that we should be targeting. So AVT has absolutely got a place. I think Copilot is a game changer. And for me, in the many years I've been a CNIO, where I've been asked to, at exec board, prove that I have given time saved to care and release time to care, and I've very rarely been able to do that in the timescales of EPR implementation that I've been constrained against. Copilot can do that instantly. So for midwifery colleagues who are coming at senior level, who are consumed by their documentation burden, it absolutely has a place. It is life-changing for them. And I would also say, sweeping statement, very often it's not our number one skill. You know, we're clinicians at heart, and actually that admin bit, the more senior you get, board papers, presentations, audits, data, all of that takes us, and I'm speaking personally, takes me a long time. You know, it can consume me. So when I did the DMA back in the day for a huge organization, it took me forever actually to correlate that data, present that data in meaningful form, be comfortable and confident with the data that I was presenting. Took me hours. Copilot overnight, well, seconds. Copilot, you can push that into the machine and go, translate this data, give it to me on a 5-slide PowerPoint slide, and put common themes in there. All of that will save us time, and that does release time to care, because that releases us to be at the forefront, visible, looking at quality and looking at all of the things that we should look at. However, the word of caution is we are professionally registered clinicians. So if you choose to submit stuff that you have never checked over, you hold huge risk there. So I keep saying to people, it's the 80-20 rule. It will do the 80% for you, but the 20% you own with your professional registration to check it over and go, this is mine, I'm happy to sign this off. I think that's the same with AVT and anything. The minute you are just clicking and submitting with your name on it, you hold yourself at huge risk, because we're the professionals. And do you know what? If technology was going to take over us and they didn't need us, watch this space. But actually, until that happens, we're the ones, we own it. It's our registration against it. You have to be comfortable and confident with what you're signing off. But it's an absolute game changer for us. And I wish it was a level playing field actually for doctors, along with our medical colleagues.
Jackie, Misbah?
Yeah, just completely echoing what Jackie said. I think the important thing is here is using it safely, and I think it's kind of being branded as AI as the fix for everything, and it's sort of like a blanket that we're just going to put over everything. But like I always say, digital is an enabler, and we have people and process, so we need to make sure that our people, whether that's our staff, or our service users, are on board and using it as well, and make sure that we're using it safely. And again, like Jackie said, ultimately we are accountable for the care that we're providing.
Jo?
I think it's really interesting about the fact that, yes, of course, AI has been utilised more in reviews with doctors in clinics and things like that. And I guess it's just because it's simpler. It was an easier fix because it's just a body of text. They can take a whole conversation and they put it in a chunk. Whereas the sort of care that midwives and nurses are doing, it's a blood pressure, it's a fundal height, it's a vaginal examination. So those need to go in the certain boxes. So I think it's more complicated. But how amazing would it be if we could be in the labour room and not have our faces towards any sort of screen, and we can just be focused on our labouring women, and we could say, fetal heart is 154, that gets documented, and then continue that conversation, and baby's doing really well, you keep going. Would it be all right if I did an vaginal examination? It's been consent has been documented without me doing anything. You know, how amazing would that be? And you can just get on with the clinical care. So I would love for AI to be fully implemented, but I just don't know how it's going to happen. I'm not techie enough, but it's only ever going to be as good as the data we give it at the moment. If we want it to learn on what we are already documenting, and we know that our data quality is not great because fundamentally our digital literacy is not so good at the moment. So it kind of goes back to what we've just been talking about. So yeah, we need to have the good foundations put down before we can build on it. And you need to be able to walk before you can run. And if we can't even get automation in place, I can't anyway, because we haven't got the resources. How on earth are we meant to try and get AI in place?
Joe, we're running out of time, so can I come to you? But could you also add your kind of summary points that you'd like to use, and then I'll come over to you, Dawn. Thank you, Karen.
Yeah, I'll just briefly say that I think we've got to be very careful with AI in terms of it's not always the answer. So it's running before it can walk, and just being really cognizant of what's around and what's being used. There's a lot of work going on behind the scenes to get a repository together to make sure we can reflect good practice that's happening out there. And I think it's really important that the CSOs are upskilled in AI now. That's absolutely crucial. The other aspects that I was going to talk about was not just data quality, but I think AVT can definitely answer a few issues in maternity care, but I still don't think we're on board there. Like Jackie said, I think it's very medically focused, and I know there's a lot of conversations currently happening in the space to say, where are the nurses? But it's still a little bit segregated. So NMAP, can we keep going NMAP instead of nursing or separating out cohorts of people, because we really need to face this together. And I have challenged one of the systems in being able to cope with AVT in an obstetric emergency. So it'll be interesting to see if they pick up that gauntlet.
Karen, it's I've seen it myself in lots of Royal Colleges running individual AI training and modules and feeding back to the centre, and it is missing folks out. And there's also shared learning between groups, so it can be segmented, but there needs to be that kind of groundswell as well of people coming back to the centre. Final summary points. I'm afraid we are running out of time, so Dawn, please. Thank you.
Thank you. I think the problem is we're so risk averse, aren't we, in maternity services? But just as an FYI to you all, ambient voice technology is currently being trialled at a trust in London in their antenatal clinics. So we'll wait and see what that generates. And then my final point, I just think it would be remiss for me not to say, we are about to launch a world first AI system, which is MOS, so your maternity outcomes signal system, and that will be coming to you in November. So, and that is an AI generated thing, but yeah, there we go.
Certainly is. Thank you, Dawn. Ms. Beck, can I come to you for your final remarks?
Yeah, of course. Yeah, I think obviously it's that key point of remembering that this is a 10-year plan, and it's not, and it will take time to get there. And I think the big thing is use your networks, use your connections. Like Joel says, deal with pride. You know, we've all got learning and that we can share, and I think everyone would be willing to share that as well. So yeah, definitely use your networks.
Thank you, Ms. Beck. Jackie?
Yeah, just a missed point for me, which I feel like I have to say, and that's the shout out for community midwives. So I think with the left shift, which we all agree with, the funding model's got to change for the left shift in order to enable it. And for me, in my years of it being a CNIO, community midwives have had a really raw deal, actually, working in people's homes, high risk, the highest risk ever, because they're in a person's home, a woman's home, making, you know, clinical decisions, a really, really important part of a woman's journey, unable to connect. So, you know, we give them digital systems that they can't connect to, and they're writing on paper and going back to the office and transcribing into the digital system because they can't connect. So we've got to look at infrastructure, offline solutions and support for any community practitioner that we've got. The 10-year plan left shift is absolutely right, but we have to do the basics brilliantly before we start looking at the shiny stuff, and we're doing them a disservice currently, I think it's fair to say.
Spot on, Jackie. Joe, final words from you.
Yeah, I think it's a really exciting time to be in digital healthcare, and that we've got potentially a lot of change coming But I just think that we just need to remember to focus on who we're doing this for. We're doing this for our patients, for our women, and they need to be have access to it. If, you know, access to care mustn't depend on their access to Wi-Fi or devices or their money or their deprivation level or their language. And digital transformation, it means nothing if it leaves our patients and our women behind.
Thank you, everybody. There is an awful lot of things in the 10-year plan, and a lot of it is ambition rather than set out kind of flow charts of this is what we need to do. But there is also massive opportunity, I think, for everybody to make a shift change. You know, there is quite a large investment that's backing up that technology. Technology has moved on quite a lot since the last national programme for IT that we had on a similar kind of scale and similar kind of ambition. And I think there is a bit of a pause by some people in the market, waiting to see what might happen. And I think one of the things that we would probably all urge in our panels across our networks and various colleagues is get on and do stuff. And as Misbah said, speak to your network, speak to your colleagues, get that learning. You don't just have to sit on the computer and read a best practice paper. You can work with your colleagues and they will help you through an awful lot of things. I've seen it work really well. Final point for me. Thank you, everybody, for joining us. Thank you, everybody on the panel, for giving up your time, particularly Dawn for parachuting in at the last minute. Really insightful and super helpful. And if I was a midwife, I'd be really pleased that I'd have you as my colleague. So thank you again, everybody. Take care and have a fabulous weekend.